Good afternoon, all. Welcome back after this tea break. Now we are going to start very interesting session. Please take your seats. So now the session is for double trouble navigating HIV and comorbidity. Here we want to see that what is the double trouble and with aging we are seeing the comorbidity and what happens to these HIV positive, those who are on ART. So it's a very interesting topic to know about.
रिलीज करते हो आपके चैनल पे
Learner
लाइक
speaker
लोकेशन
also.
लाइक यूट्यूब
If
you just send some links to the
she's going to
YouTube
talk
channel.
about
No, right,
lipid abnormalities
CNA
in HIV
channel.
infection.
ASICON welcomes Dr. Trupti Gilada.
Mentions.
Dr. Gilada is a consultant physician in infectious diseases at UNAIDS Medical Research Center, Mumbai. Dr. Trupti Gilada is a highly qualified consultant physician specializing in infectious diseases. Dr. Gilada is also affiliated with Prince Ali Khan Hospital in Mumbai, expanding her reach and impact. She holds an MBBS and MD in Infectious and further specializes in fellowships in infectious diseases, HIV/AIDS from Harvard University, respectively. Dr. Gilada's expertise has been recognized by the International AIDS Society, which awarded her the HIV and Drug Abuse Fellowship in 2014. Her work at leading medical centers and her advanced training highlight her commitment to providing high-quality care to patients with infectious diseases. We look forward to hear her talk on lipid abnormalities with RQs in HIV infection.
Good afternoon, everyone. I think they timed this session well, just pre-lunch, to make you more aware of what you're going to be having for lunch. So, we'll, in the next 12 to 13 minutes, we'll just look at what lipid abnormalities with ART are. These are my acknowledgements, and I have nothing to disclose except that I've really enjoyed fat-rich food here in Gujarat, and will probably do so for the next 2 days. So it's great that from discussing about OIs and late HIV infection, we've actually now started to discuss more and more of diseases under the spectrum of metabolic syndrome, because that's a good sign that our people are living longer, and we need to know how big the problem is. What do we test? How do we stratify those at high risk, and what do we do once we know who's at high risk? So these are graphics and numbers, but we all know that over the last 2 decades, the percentage of people that fall in the age group of 50 and above is slowly increasing. And that's thanks to the highly active antiretroviral therapy, early diagnosis, and putting people on treatment as soon as they're diagnosed. But lipid abnormalities are becoming a problem. They are common even in those with ART. In fact, 1 in 5 people with HIV have moderate to high cardiovascular risk. This is because of increased longevity, but also because of the HIV status and the things that come along with it. And we know that a lot of other traditional risk factors are like hypertension, diabetes, and smoking. HIV disease per se, even without that, just HIV infection itself is a risk factor for dyslipidemia and coronary artery disease, and that's because the HDL drops and eventually the TG rises. And when we modify this with ART, while we might take care of a lot of factors that continue to persist are inflammation. We know that now that despite ART, a level of chronic inflammation in the body persists. But ART itself comes with a lot of side effects that happen at the cellular and the molecular level. And while initially with the earlier drugs we saw a lot of lipodystrophy, especially with statine and zidovudine, we still see these patients with telltale signs of having taken those drugs, where there is loss of fat from the extremities and the face, and there's deposition on the shoulder, in the abdominal area. And we know that there are some drugs which are more likely than the other drugs. And this is just a list of what each drug has its impact on the lipids. But when you see this list, we will see that most of the drugs that really impacted the lipids significantly are the drugs that we've slowly moved away from. So whether it's lopinavir or zidovudine or nevirapine. And if you see this list of ART drugs, the drugs in those that have the lowest risk of causing dyslipidemia are the drugs that we are using most commonly. So whether it's in PIs are most commonly used is atazanavir, ritonavir, and tenofovir, lamivudine based regimens, and in C, dolutegravir. So while with PIs we do deal with dyslipidemia in terms of low HDL and high triglycerides, the others, and this is talking about metabolic syndrome per se and not just lipids. We now see that with dolutegravir based regimens, and the green graph here is the dolutegravir, and we all have weight gain as an adverse effect of dolutegravir is becoming more and more prominent, and what that has as its future implications on metabolic syndrome is now being more and more understood with years of dolutegravir use. And dolutegravir, it's a very lipid safe drug, but it still plays on the metabolic syndrome in a different way. And that is adding to, driven by obesity. And if you see two of these data from two of the studies, the ADVANCE and the NAMCEL trial, where if you see this, the dolutegravir based regimen had a really high odds ratio of having increased weight gain or obesity. In addition, is more likely to cause hyperglycemia. In fact, the adjusted odds is 7 times, and more so with increasing age. With increasing age of 55 or 56 and above, it really goes to even 12 times. And that's about hyperglycemia, and the same even for hypertension. So while we talk about dolutegravir being safe on lipids, it's adding to the metabolic syndrome in other forms. And therefore, while we are really happy with the kind of ART that is now available, I think we need to be more and more aware and look for its other side effects. We don't have the data of clinical prescription and clinical knowledge about these syndromes from India, but this is just to show you from the US and from our LMIC, where physicians were less likely to prescribe statins to HIV infected patients, and this is adjusting for all the other risk factors. So, as HIV clinicians, we feel we've given ART, we prolong life, and we often forget that there are other things that we need to look at. And this is from a study in Uganda where they checked the knowledge, attitude, practice amongst HIV physicians, and many of them were not aware of the metabolic disorders. So moving to that awareness, what do we do? Who do we test? So every patient ideally should receive a lipid test prior to initiating ART, and within 1 to 3 months after starting a new regimen, just to understand what is that new drug doing to that particular individual. And once we've done that, we can follow it up every 1 to 3 years depending on what the baseline was. To assess the cardiovascular disease risk, the preferred test is definitely a full fasting lipid profile. Oftentimes that's not possible because at the ART centers of patients will come in the afternoon or they're not fasting, and therefore an initial screen even with just total cholesterol and HDL cholesterol is enough. The goal is not just to identify those who are candidates for lipid lowering therapy, but also to identify who is at a higher risk of cardiovascular disease. And when we talk about cardiovascular disease, there are very well used calculators. One of them is by the American College of Cardiology, which is called the atherosclerotic cardiovascular disease. And here I just entered a typical male patient that we would see. So here you put in the data. So we enter the data for a 58-year-old male, and HIV itself is considered as a risk factor. So we check off that others category in this. So by itself, HIV is a risk factor. We enter the blood pressure. You will see he's not really hypertensive. We enter the cholesterol values. He has history of diabetes, blood pressure, is a smoker, and is not on any therapy. And the lifetime atherosclerotic cardiovascular disease risk is almost 70%. Okay, so that's a really high risk. If we were to visually show the patient this, that with your factors, this is your risk of getting a cardiac disease. Just seeing that visually really helps. And when you start telling them you quit smoking and you add another 2-3 years to your life and control your blood pressure, take your medicines for diabetes well, and you'll add another few years. And this is the ideal candidate for whom we would definitely start a statin and think about aspirin therapy. And of course, this is someone with a really high risk, but just to stratify the patients that we see on a day-to-day basis. So if we were to stratify our patients, so someone less than 40 years of age is a low risk and doesn't need to be evaluated in the sense of someone that are very high risk and will follow all the guidelines that an HIV negative individual will. But with someone who is HIV infected, in the age group of 45 to 75, we do an LDL and preferably also do the ASCVD score. If the LDL is more than 190 or the score is more than 5. Now see, we were looking at that as a score of more than 70. This is just score of more than 5 is already a candidate to receive a statin. So if we were to understand this, when we really evaluate all our patients, we will see a lot of our patients are candidates to statin therapy. And someone with a risk of more than 20 is a high intensity statin, and someone with a moderate risk is a moderate intensity statin. Will come to those dosages. And someone who is at an LDL of less than 190 with a low score, there might still be people who will benefit from a statin therapy. These are people with low CD4 counts, with already presence of lipodystrophy or atrophy, who already have some other risk factors in the metabolic syndrome. So maybe blood pressure or obesity, someone with a fatty liver disease, which is also very common in our population, and co-infection with hepatitis C. So these are who will benefit from statin therapy. So who we give statin to will depend on their LDL levels, our ASCVD score if we have, and depending on what is their current ART regimen. The benefit of lipid lowering therapy is relative. So if the risk is higher to begin with, so if the ASCVD score is high, there is a higher risk of serious cardiac event, and therefore there will be a higher absolute benefit of starting a statin. So someone who starts with a very low risk will have a lesser benefit of starting a statin, and that's pretty obvious. But when we are to see this and stratify it on a table form, of course this is a very busy thing, but what I wanted to show you is that someone with a 0 or 1 major is a low risk. Someone with 2 major risk factors, and if you think about it, HIV is 1 risk factor. So one other risk factor, be it hypertension or obesity or sugars, already puts our patient into a moderate risk category. And for someone in a moderate risk category, any cholesterol above 160 or LDL above 130 is an indication for statin therapy. So what do we do with these patients once we identify them? The most important thing is talk to them about lifestyle modifications, because that has a benefit across whatever category they fall in. And then lipid safe ART, lipid lowering therapy, and handling other risk factors that might be there. So if, this is a beautiful graph that shows us that by doing one additional intervention, the benefit in reducing the cardiovascular risk. And when we do all of that together, it really multiplies. Coming to pharmacotherapy, statins have really shown to have a very good benefit in reducing cardiovascular disease. Those who have a triglycerides of above 400 also warrant the use of fibrates. The other molecules like omega-3 fatty acids, ezetimibe and niacin are also beneficial. The reason I put them in grey is because we do not have specific data in the HIV population. For us in the Indian setup, what does the statin mean? I've put down the doses here. For a moderate intensity, it's around 40 milligram of atorvastatin or 10 of rosuvastatin. And for high intensities, 80 and 20. There is some data, new data on pitavastatin, and pitavastatin is now available to us at 4 milligrams. So this is just to show the benefit of pitavastatin and how it really reduces the risk. we saw that most of our newer drugs fall in the lipid safe category. And just to show you again how there isn't a drug-drug interaction of our newer drugs with the statins we use. And of course, I think Christoph will be covering this is, other things that we need to take care of in aging is diabetes, hypertension. Aspirin use, there hasn't been, 2 studies haven't showed any specific benefit of reducing the inflammation, and therefore it's not just HIV per se is not an indication to start aspirin. So to conclude, this is the elderly gentleman that we saw on a Vande Bharat flight, Vande Bharat train from Mumbai to Ahmedabad, and it was just so wonderful that even with glasses, he was trying to use a magnifying glass to look at and read the paper. I think that's what we need to do is, get into further detail into the clinical profile of our patients and really see, expand our management focus to include metabolic complications, strengthening our screening categories, screen them with very simple tests, sugars, lipids, really talk about lifestyle modifications. That's something that we do not talk about often but has the maximum impact, and really evaluate the need for statins. So most good things come with the risk of something bad. I'm sure all the husbands will agree to this. So, at least you have something good. Think about us. So, thank you so much. And if there are any questions, you can ask those questions to Christoph because he's going to be the next speaker and will probably cover the things that I've missed. Thank you so much.
Thank you for that excellent presentation. Because HIV/AIDS is itself a condition and addition for cardiovascular conditions. But one observation before we that we have Atorva and Roswa and we have Pitava, and we have seen that in higher doses, Atorva or Roswa, like Roswa 40 and those who have gone in intervention, then Atorva 80, and for that dosing there is PPIs and there is interaction with this protease inhibitors, if we can say. So why it is not yet promoted Tavastatin, which is excluding this pathway and very safe, and we have seen that every alternate prescription in Indian condition is having PIs, and they have also interaction with the same pathway. So when we have safe, this pathways, and why it is not yet promoted, the Pitavastatin, it was my observation. Thank you very much. And any questions?
We'll take the questions at the end of all the talks.
So now we are having the next speaker. That's Dr. Christoph from Germany, and he will be talking about HIV and aging. As we all know that aging in our current data of Indian government suggests that the 10% population is more than 60 years, and by 2030 we will be getting 20% of population of more than 60 years. The same way US and other countries, they are having more longevity of HIV positive on ART. Same of the patient continuing on ART and surviving longer without any issues. But aging develops other morbidity and other issues for managing this HIV and aging.
ASICON welcomes Dr. Christoph Spinner. Dr. Christoph Spinner is the Chief Operations Officer for Hospital Operations, TUM University Hospital, Germany. He was the local co-chair of 25th World AIDS Conference 2010. He is a consultant physician in internal medicine and infectious diseases and holds an adjunct teaching professorship at the Technical University of Munich. Dr. Spinner's medical training includes studies at Albert Ludwigs University Freiburg, University Hospital Zurich, and Ruhr Hospital University of Cape Town. He holds a Master of Business Administration from the Technical University of Munich and the University of St. Gallen, complementing his medical expertise. Dr. Spinner is actively involved in research and has published in numerous medical journals.
dear organizers, dear esteemed colleagues, dear Dr. Gilada, I'm pleased to be back in India, as I've been here last time for the first year in Kerala, but it's even nicer to see you all colleagues this year again. And I'm happy to deliver a talk on HIV and aging. Dr. Gilada has already introduced several important aspects of aging. And before I continue, I want to disclose some conflict of interest statements, but I'm free for any COIs for that talk. So what is the role of age in HIV? 25% of all people living with HIV are 50 years and older, and we've seen a numerous 50% decline, which is a reduction in HIV-associated deaths as compared to 2020 due to or as a result of the enormous advances of antiretroviral therapy. This is the case for almost every region except the Eastern European and Central Asia. And as people living with HIV who are on treatment get older, comorbid health conditions among people living with HIV need to be taken into account for programming, states the UNAIDS report of 2024. More than 10 years before, the UNAIDS 2014 GAP report already identified that there was a high number of people living with HIV being aged 50 years and older. It is entirely more than 4.2 million people back then, and even in the sub-Saharan African area, it is more than 2 million people. And as this report is 10 years of age, the number of people living with HIV has even further increased. There's a model for the Netherlands that estimated more than 70%, which is 2 out of 3 patients, will be 50 years or older by 2010. So how is the situation in Germany? May I describe? We do have the same situation as the UN GAP report from 2014 introduced. Every second person living with HIV in Germany is 50 years and older. We expect exactly the same. 2 out of 3 will be 70 years and older. 70% will be 50 years and older very soon. And that requires us to deliver a specific care and management plan to those patients. So why is age and HIV interacting? And what is the dedicated specific points of interest that we as care providers need to bear in mind? We just pointed out 6. Aging and frailty, mental health, kidney disease, hepatic disease, cardiovascular disease, which Dr. Gilada already introduced the scene, disease. And there's even more. However, in my 10 minutes of talk, I want to draw your attention to 4 specific points of interest. Medical, which is polypharmacy, multimorbidity and frailty, and psychosocial aspects. However, there's others also interacting with HIV, which is late diagnosis, because late diagnosis in older patients is an additional challenge, and the oldest patients I remember being diagnosed with HIV was 82.5 years from a chronic proctitis, which was strongly associated due to chlamydia and syphilis co-infection. However, the practitioners did not even expect HIV as a possible differential, resulting in delayed diagnosis at a later setting stage. So once all those factors are interacting with HIV, I'm completely aware that the practitioner's reality is very different within our different settings. And I want to start with polypharmacy. Why is polypharmacy an additional challenge? We've heard already on potential interactions from the chairs of that sessions regarding statin therapy and antivirals. And the current European guideline, European AIDS Association guidelines, is offering more than 100 pages on managing comorbidity, which clearly highlights that comorbidity is nowadays even more important than the antiretroviral therapy itself, because while ARV is becoming more effective, highly tolerable, and more easily to manage in the majority of our patients, comorbidities are increasing as a result of the highly effective antiretroviral therapy. In the different practitioner settings, effective cooperation between HIV specialists and other medical specialties is crucial In the setting where I practice, is both base established, either HIV practitioners that do offer full internal GP and internal medicine services. In others, it isn't. However, in any cases, we need to bear in mind that there is more than HIV as a problem to our patients. Coming back to polypharmacy, so what is the problem and what is polypharmacy? Polypharmacy is defined as 5 or more medications, and the increased medication use is associated with less adherence because it might result in pill fatigue. The more pills patients have to take, the more likely they are to be tired of taking them. It increases the risk of adverse drug events. DDIs and disease interactions might increase. Geriatric syndromes such as false cognitive impairment and frailty is an additional struggle, and even mortality. There are several studies that clearly predicted polypharmacy as one of the strongest predictors of serious adverse events, drug interactions, and fall risk. And that's the main interest when we need to bear those challenges in mind. So how should we judge, how should we manage those problems? I know it's very tiny text, so it is the actual graph of the EX guideline, how to manage DDIs and polypharmacy, and just summarize the main conclusion from these sections. It is important that you regularly review the age-related comorbidities and co-medication in all your patients, which we do at least on a quarterly basis, because polypharmacodynamic and pharmacokinetic effects should also be taken under account. There is a top 10 list of drugs that should be avoided in elderly patients, which is, for instance, tricyclic antidepressants, benzodiazepines, atypical antipsychotics, and many others, including stimulant laxatives and others, because their risk of DDI is far higher in people living with HIV than in the older population. However, all those drugs should be avoided in elderly because several pharmacokinetic effects are reported that they are slowly metabolized and there's more challenges than DDI alone. Once you're not the single care practitioner of your patients, educate other practitioners in the setting, which is cardiovascular specialists and any others, that they should be aware of those DDIs as well. I mean, nowadays, every one of us knows that DDI of statins and boosted antiretrovirals is a huge challenge. That is a knowledge that every internal medicine, cardiovascular, or any other specialist should have as well, and it's easy to keep it once you know it. So coming back to the German setting and the problem of multimorbidity, which is the next topic. As we've learned, polypharmacy is strongly associated with multimorbidity because when there is more than one medical problem, it's very likely that you need to take more than one pill. And this is a study we've drafted and published a few years ago. More than 450 individuals in more than 20 centers, 20% of females, which is a typical females in the German HIV population. And what you see there is by people being aged 60 years and older, the likelihood of having 4 or more different comorbidities was far above 60% and 3 or more even above 70%. What kind of diseases is that? It's depressions, blood pressure disease, hypercholesterolemia, and many others. And to sum it up, multimorbidity is associated with increased mortality and frailty, which is shown you before, and you can see that those underlying comorbidities is frequent even in our German condition. So that strongly reassures us that we need to bear in mind and to manage those problems. And just recently, there has been a new study published in The Lancet that assessed multimorbidity in a larger cohort, and morbidity due to comorbidity is, I've told you that before, increasing, which is strongly the case for cancer, which is the orange line, cardiovascular disease, and the dark orange, while the originally HIV-associated infectious or AIDS-associated mortality is declining. And on the adjusted cost-specific mortality rate ratios are given, where clearly is presented in more detail, what I've said before, the infectious comorbidity is decreasing while the non-infectious comorbidity is increasing, and that requires HIV specialists to not only be advocating HIV. Trupti has already introduced the new lipid goals for people living with HIV. I don't want to get back into detail, there's just two more things I want to highlight. One, there is new risk calculators. We've seen ASCVD. We are using more this tube calculator, which is only validated in a non-cardiovascular ill population. I wanted to keep that in mind. And second, FIVA was the first European guideline, but nowadays EACS and even the German practitioner guidelines have changed. So statin therapy as a result of the published pitavastatin studies is recommended for all people living with HIV above the age of 40, even once they have a mild to moderate risk. And what Trupti nicely introduced is that the lipid goals is strongly dependent from the overall risk, so it's not a fixed target anymore. Bear in mind, you need to assess the LDL and individual risk. Trupti has also spoken on diabetes. There are several studies. This is just one example, the RESPONSE study that found increasing diabetes risk in people living with HIV. INSTIS is a large study, it's almost 21,000 subjects followed up over a longitudinal period, and the increase of BMI was strongly associated with diabetes mellitus. This is an additional hassle to manage. How to manage diabetes, I don't want to go into the details due to time-constraining issues. However, it is important, as compared to cardiovascular risk, to bring your patients back into targets. We have new powerful instruments, including GLP-1 analogs, a drug that is able to not only reduce the diabetes disease progression, but also reduce risk, which is the risk of weight, which is the most important risk factor of diabetes. How about the overall role of GLP-1 analogs in people living with HIV? In our practice setting, I say the use of those drugs is increasing, mainly in the obese population, and the outcome is powerful because several studies show that there is an overall reduction in mortality and morbidity in non-HIV populations, and there's first studies coming up in HIV populations as well. But what about cancer? Cancer is also a huge challenge. We've learned from the early days of HIV and AIDS, this HIV-associated cancer is a large or a relevant problem in our patients' cohorts. This is a study presented at the EACS back in 2023, which had a closer look at the French HIV cohort and it confirmed what we've known so far. And even the non-HIV-associated cancer is a huge challenge. So coming back to the two last points, frailty, what is it? Frailty describes a decline in multiple psychological systems. It increases the vulnerability to minor stress events. It is a concept of disease results out of many reasons or causes, and the phenotypic presentation is slow movement, weak hand grip, and many other decreases of function. How to assess and support our patients? Actively screen in the aging population for frailty, manage existing psychological comorbidities. I've shown you a few of them. Review antiretroviral therapy and modify, if appropriate, promote a healthy lifestyle because exercising and sports is the most effective preventive way in an aging population, and manage the risk of polypharmacy and poor adherence. There's different instruments of phenotype assessments or index assessments of frailty. I've just brought you the links. Once you share the slides afterwards, feel free to have a closer look into and some how to apply best medical practices to our aging patients. Manage polypharmacy, multimorbidity, and frailty as presented in these presentations. And as a last aspect, I want to draw your attention to aging impact on mental health. So aging people living with HIV are more likely than younger to experience depression, social isolation, loneliness and rejection, adverse clinical outcomes, and lower status disclosure. All of this is negatively impacting on your patients, and I'm completely aware that in resource-constrained settings, there is more social, behavioral, structural, or biological barriers that even do influence the managing of the elderly population. With that, I want to conclude and sum up. Comorbidities, sorry for that, comorbidities are relevant in people with HIV and increase with age. DDIs should regularly be re-evaluated and polypharmacy should be managed. Cardiovascular death is relevant and lipid-lowering therapy reduces mortality and morbidity. Newer studies showed. Malignancies considered to be very important, although there is prevention strategies needed and specific programs for increasing testing and access in elderly might support access to treatment and care, and integrated care approaches should be discussed. And with that, I want to thank you and those of you who have attended last year's 25th World AIDS Conference in Munich, and thank you for having me back here in India.
Thank you, Christoph, for the excellent presentation. We will have questions after the last session, and the next session is going to be very important, and more so in our place also, Bihar, in remote area, remote villages of Bihar. I have not seen in 20 years any injectable drug abuse, but in 6 months I have seen 6 cases of HIV with infected Hep B or Hep C. So now this update, we request Dr. Rockstrom from Germany to come and update us on this, because it is becoming a very important.
ASICON welcomes Dr. Jayendra. Dr. Jayendra Rockstrom is the head of Infectious at the Department of Medicine, University Hospital Bonn, Germany. Dr. Rockstroma's career combines significant clinical practice with impactful research, making him a key figure in the field. He has held numerous leadership positions in prominent organizations, including chair of the German AIDS Society, UNAIDS, the German National AIDS Advisory Council, and president of AIDS. Dr. Rockstroma's influence extends internationally through his involvement in conferences like the World AIDS Conference and his work with organizations like the UNAIDS. His research spans a wide spectrum of infectious diseases, from HIV, AIDS and STIs to hepatitis, tuberculosis, and antimicrobial resistance. We look forward in hearing him talk on update on viral hepatitis and HIV co-infection. What is new?
Good morning, everyone. Let me just say, after Christoph's and Trupti's talk, that the best thing we did yesterday was dancing together, because moving is prevention for aging. So thank you for that. My topic today is viral hepatitis and HIV co-infection, and that makes sense, as obviously there are overlaps in these epidemics, clearly arising from shared transmission pathways. So not so surprisingly, we expect that many people living with HIV also come down with hepatitis C, which can be as high as 70–80% in people who use drugs. Or overall, they do affect around 10 to 15% of all people living with HIV, and around 6% having hepatitis B co-infection, and very few having delta superinfection. Now let me talk you through the 3 different hepatitis viruses which are relevant for people living with HIV, starting with hepatitis B. And what we shouldn't forget is that in the setting of co-infection with hepatitis B, fibrosis progression is accelerated, and in the days without antiviral strategies for management of hepatitis B, people were very likely to die from co-infection. So remember, liver infection or co-infection with viruses takes a different course in the setting of HIV, which makes management of these underlying co-infections so important. So if you refer to the wonderful EX guidelines in the newest version, you will see that anyone who has detectable HBs antigen above 6 months, that's how we define chronic hepatitis B, should receive an antiviral therapy, which either includes TDF or TAF, unless there's a history of tenofovir intolerance, to match both viruses at the same time. There has been some discussion with TAF and TDF being available. Is there a difference between the 2 components with regard to hepatitis B treatment? And there was a recent trial called Alliance, which was a study comparing dolutegravir with TDF and FTC versus BF-TAF, so really having a second-generation integrated inhibitor comparing TAF and TDF. And they looked at the overall outcome. There was no difference in HIV control, so that worked very well for both regimens. But as you can see from the graph on the right-hand side, although the figures are relatively small, you can see that there was a higher rate of HBe antigen loss. And remember, in the setting of HIV, when you start antiviral therapy, because of immune reconstitution, you may experience at a higher rate HBs antigen loss or HBe antigen loss, which would be the ultimate goal of hepatitis B treatment. So some people have speculated whether TAF may be more potent because of the intrahepatocyte accumulation of the compound, although I think it is worthwhile to point out that, first of all, HBe DNA levels, so suppression of HBe replication was comparable. If you look at the flat curve, that was the same. And I would speculate that there were some baseline differences which were in disfavor of the dolutegravir arm. There were some people with higher HBe DNA at baseline, and we know that the level of viremia is the best predictor for achieving undetectability. So probably there was a little bit of disbalance, and over time, the initial observed higher rate of HBs antigen clearance was no longer maintained. So it could be that after extended periods, actually there's no real big difference between TAF and TDF, but of interest is the higher HBe and HBs antigen loss in people living with co-infection. And this is also highlighted in this German national cohort analysis, which looked at 359 individuals with HIV and HBV, which were followed up for a really long time of 11 years and had significant immune reconstitution. And you can see that 18% of the individuals lost HBs antigen. And remember, if you do tenofovir or TAF treatment in monoinfection, the rate of HBs antigen clearance is less than 1%. It doesn't occur. TDF or TAF do not lead to seroconversion. So it's really that people who got infected while they had HIV were immune deficient would have cleared the infection naturally, were not able to do so because of the low CD4 count, but once the immune system was reconstituted, they were able to clear infection. But that, for us as clinicians, means that someone who has HIV and HBV may actually clear infection over time, which would require serological control of these markers. Remember, particularly for those individuals who come to their care, and I saw this very nice presentation yesterday from the colleague who reported about the acceptance of hepatitis B vaccination, particularly the trans population, which is obviously at higher risk, was less than 6%. So obviously hepatitis B vaccination is often not performed. There are 3 vaccination steps. It's complicated. So remember that if you start someone on TAF or TDF, independently of the hepatitis B status, you will see that it protects against HBV infection. It's like a pre-exposure prophylaxis. This is nicely shown in the Amsterdam cohort, which illustrates that individuals who were on TDF had no new hepatitis B infection, whereas there were very few, but some in the 3TC or FTC containing arm, and there were quite some infections in those who had no anti-HBV active drug, which illustrates if you're at risk of STI or of HIV, you will remain at risk most likely, and so hepatitis B may occur, and you could be protected by including that into your antiviral therapy. One of the important things to remember is that liver cancer is an impending risk of hepatitis B co-infection, which is higher than if you have chronic hepatitis C, where this mostly occurs in the setting of cirrhosis. In the setting of HBV, this may occur independent of cirrhosis state. Remember that anyone who has cirrhosis needs to be screened for hepatocellular carcinoma, and that should occur according to the EX guidelines in line with the EASL guidelines, which propose the PHB score to be used to assess the HCC risk. Ultrasound is also recommended, can be with or without AFP. AFP is the suboptimal tool. Patients with particular risk for liver cancer in the setting of HBV is a family history of HCC, Asian or African ethnicity, HBV co-infection, and being older than 45 years. Now, the PHB score is something you have to familiarize yourself with. It is a score which includes platelet count, age, and gender. So not so complicated. You see on the right-hand side, the lower part of the slide, the risk attribution. So depending on age, the older you get, the more points you get. Female, less risk than male. And then you can see that the platelet count as a marker of advanced fibrosis. Remember, that's also part of the ECRI score, alludes a higher risk. And this was then examined in the Swiss, the Dutch, the French, and the European Eurocida cohort. And what you can see, interestingly, is that if you had a page B score above 9, on the right-hand side, you can see that the majority of the 68 liver cancers which were observed in this 4-cohort analysis occurred in that kind of individual. So if you have a high page B score, your risk for HSC increases substantially, and that's why this score is, I think, helpful in sort of identifying who is at a higher risk and should receive ultrasound examination. So obviously, in order to prevent hepatitis B, vaccination is very important. I just want to highlight that in the EX guidelines, there's very specific guidance on how to perform hepatitis B vaccination. So at best, when you have started antiviral therapy and once the viral load is undetectable, your response rates will be higher. And there's also some guidance on which levels of anti-HBs, preferably above 100, you want to achieve. And then there's also a mention of a new vaccine. I did not see that on the slide yesterday. It suggests that you may not have CAPRISA available yet here. In Germany, it's available but not reimbursed, so it's sort of a similar situation. The HEPLISAV vaccine, though, is, I think, of great importance because it has been studied in the setting of people living with HIV. It's a new vaccine with an immune modulator, so it basically has HBs antigen coupled with a different adjuvant, and this adjuvant is proposed to cause a greater immune response. And in this prospective ACTG study, they looked at various patient types. The one I want to present here is the one which did not present or did not respond to a conventional hepatitis B vaccine. So they were already vaccinated before, had no adequate response, and were then randomized either to receive standard vaccination with Engerix, 3 doses at entry at weeks 4 and 24, so that's sort of a double vaccination after a previous failed one, or 2 doses of the new vaccine, or 3 doses of the new vaccine. And what you can see is that the overall response rates were much better in this new immune-modulated vaccine, with 99.4% responding in the 3 administration schedule of that new vaccine. And that's really important because that means that if people were priorly non-responsive, you can achieve a response of pretty much everybody. And that is really, I think, a dramatic change in what we had before. You see the distribution of anti-HBs titers in this slide. You can see that indeed in the classic Hep B alum 3-dose vaccination, and this is a revaccination schedule, you can see that 20% have either no or less than 5 international units of response, and you can see with the 3-dose vaccination, it's much better. So I think that is something we should think of for the future, that better vaccines are becoming available. And why is hepatitis B vaccination so important? Well, because people who have HIV will remain at risk for hepatitis B, and this is, I think, increasingly important in the setting of individuals who are now going to be switched either to long-acting or other dual therapies which are not hepatitis B protective. And this is a case report of an individual who has a history of many differently sexually transmitted diseases. He had 3 vaccinations for hepatitis B, but did not build any anti-HBs antititer. And when he was switched in the FLAIR study, which was a switch study to cabotegravir with tuberine, he developed acute hepatitis B. So I think that's important to remember. These cases exist, and if you're not vaccinated successfully, you will remain at risk for acute hepatitis B. And remember, acute hepatitis B can always come with the risk of liver decompensation and eventually either liver transplantation or death. Monitoring persons with hepatitis B and HIV. It's therefore important when you simplify someone to a regimen without hepatitis B protection, you have to repeat your hepatitis B serology to know if they're either chronic infection or is there just an isolated anti-HBC. Remember that in the setting of people living with HIV, if you have exposure, prior exposure to hepatitis B, 25% will only have anti-HBC. It's a very common finding, not so common in immune-competent people, but immune deficiency, very common finding, and that means that you can also potentially have some issues there, particularly obviously when you get chemotherapy, aging patients, high risk, so remember that. Delta is a super infection, which can only occur in the setting of chronic hepatitis B. The rates of co-infection with Delta are very diverse in literature. Co-infection rate with Delta and patients with HIV and HIV. As a clinician, I would say, how can that possibly be? You see that? No. So we decided to set up an international hepatitis C cohort compassing 9 countries, including UK, looking at the rate of hepatitis Delta, because the problem is that these cohorts, like Swiss and Eurocida, are very long existing old cohorts. And most patients with Delta have long ago passed away. So you're looking at people from the early days of HIV, and I think the true resemblance of prevalence is completely different. So in the actual numbers of the German cohort, which we'll present next month at the German Austrian AIDS conference, you can see that only 8% had Delta co-infection in the setting of HIV and HPV, and only half of them were actually replicating, showing signs of ongoing active Delta infection. So that's only 4%, so much, much less. It resembled actually that what was recently published from the North American group as well. It was striking to see at a poster presentation from Taiwan, which looked at a predominantly MSM population, that in the end 8% had Delta infection. So you had HIV and HPV in this Asian cohort of MSM. And that's the first report, because usually in MSM we don't see Delta at all. So that for me was a real surprise, but it suggests that also transmission patterns may change, and I just think you really have to all screen. And that's what EX recommends. Any person living with HIV and chronic hepatitis B, only with HBs antigen, you can have Delta infection, because that's required for replication of Delta. So remember to also perform that test in these individuals. And why are we so worried about Delta? Because among the patients living with HIV and HPV, if they get Delta on top, they all have very progressive liver disease. And I can tell you from my initial cohort of hemophiliacs, so they were all infected in the 70s, HIV test first time performed 1984, when they had hepatitis B and Delta and HIV, none of them survived to get AZT monotherapy. So they all died before 1989, just suggestive of how fast and progressive this liver disease is. Now fortunately, there's been a lot of movement in the Delta space. First drugs have been licensed, which is Lipid. It's a first-in-class entry inhibitor for treatment of chronic Delta. It's a very smart approach of preventing the entrance of Delta into the replication cycle. And this is from the French Early Access Program, looking at the virological and biochemical responses in the liver type. It's administered subcutaneously, unfortunately daily, so it's a very intensive treatment. But you can see that half of the people in the intent to treat analysis responded with more than a 2-log drop in viral load, becoming undetectable, and normalization of liver enzymes. So it is quite good, but it is extremist to inject every day, but better compounds are on their way. With hepatitis C, I think that's probably the best success story, but remember, hepatitis C also was associated with faster fibrosis progression. And interestingly, even the setting of having successful antiviral therapy, there still is a somewhat higher fibrosis progression. So hepatitis C adds to comorbidity and liver disease outcome, and that's why early treatment is so important, because the more advanced progression is particularly true in the setting of immunocompromisation, so low CD4 count, and also if you have ongoing replication, obviously then that also doesn't help. So control of viral replication is very important in individuals with hepatitis C co-infection. Now, everyone who has hepatitis C should be treated. You can cure this infection very easily. Response rates are way above 95%. There is no difference between co-infected and co-infected. They respond equally well. You should use the same drugs. All very easy peasy, nothing to worry about, except for drug interactions, less relevant in the era of integrase inhibitors, except for Gilada or glucosamine, which you shouldn't use in the first place. No reason to use that drug anymore. But that is something to keep in mind. So if you look at the drug interactions, you can see that most of the commonly used drugs are your TAF, FTC, integrase inhibitors, but also work very well. So there's some things to watch out for in the case you have these issues. That's something to keep in mind. The most fascinating story of hepatitis C is that if everyone is treatable and curable, then you would expect that elimination of well-defined patient populations is possible. And in the wonderful cohort work from Juan Berenger's group from Spain, they've been following this very accurately. And you can see that the amount of individuals who are hepatitis C RNA positive in the Spanish cohort has dramatically decreased with the onset of wider access to hepatitis C treatment. The number of individuals with active hepatitis C in Spain in 2009 was only 2.2%, so over 90% lower than before. So hepatitis C in individuals living with HIV in Spain. And I think that's great news because it does highlight that hepatitis C therapy has come to what we want as infectious disease doctors, namely elimination of the pathogen. So let me summarize. There is a significant reduction in liver-related mortality in co-infection with hepatitis B after introduction of H2B active ART. We may not be able to cure infection, but remember that with tenofovir, which should be part of any antiviral regimen in someone who has hepatitis B, you have a high chance of clearing infection, 18%. So that's good news. People who do not respond to hepatitis B vaccination, tenofovir can prevent against hepatitis B, so remember that is an option, but better vaccines are on their way. In patients with chronic hepatitis B, don't forget to screen for Delta infection. Every person with hepatitis C should be treated with an interferon-free regimen. I think there's no excuse, particularly in a country like yours where you have generic versions of the wonderful drugs available at low cost. I think there's no reason to withhold therapy in anyone. In the setting of co-infection hepatitis C, you can use the same treatments, the same schedules as in monoinfection. The only thing to worry about are drug interactions, depending on what kind of antiviral therapy you're using. And hepatitis C elimination is absolutely achievable. With that, I'll thank you very much for your attention.
Thank you, Dr. Roscoe, for excellent talk, and this is a much needed for management of CAPRI and FC, and Government of Gujarat has recently initiated this program in our state also for mainly the key population they are receiving. So thank you. Now moving ahead, now we are having very interesting case discussion from two of the IDA consultants. So first I invite Dr. Swati Goel. Yesterday we heard her. Now she is going to talk one more case, interesting case. So, Dr.
Introduction, and thank you organizing committee for providing the stage. So I am going to serve you something before the actual serve, which is common yet cryptic. So this case was presented to us in December 2022. Because it was December, I have kept it as a Christmas cake. Sorry for putting such images just before the lunch hour. So he was a 72-year-old male, a farmer from Gujarat. Patient was brought by a distant relatives or a caretaker because most of the patient's relatives and children were settled in foreign countries. Initially, patient was presented to nephrology unit with 2 months history of bilateral lower limb swelling, a weight gain of 12 kgs, and occasional episodes of hematuria. Only 3 complaints. Otherwise, no fever, no cough, no chest pain, no orthopnea. So typical medical case, but because he was having hematuria and bilateral lower limb swelling, he was presented to nephrology unit to start with. As we are learning a lot about the comorbidities, he was having all possible comorbidities. A 78-year-old male with diabetic, hypertension, morbid obesities, BMI was 39, and probably he was suffering from obstructive sleep apnea. He had a history of IHT, and for which he underwent a PTCA a few years back before this presentation. At the time of the PTCA, he was diagnosed to have HIV infection, for which he was taking ART from the government sector. That was TTF, PTC and DTG. His baseline CD4 count at that point of time was more than 250. He did not get his baseline viral load, and her spouse screening was negative at that point of time. On examination, there was pallor, bilateral pitting pedal edema up to the knee. Otherwise, vitals were fine apart from the borderline blood pressure. There were bilateral basal crepes, but apart from that, the systemic examination was normal. There wasn't any peripheral lymphadenopathy, rash, oral or genital ulcers. These were the routine blood workup. He was anemic. His total counts were fine, platelets were fine. His albumin was little bit on a lower side. His globulins were fine, and his baseline creatinine was there, which was performed roughly 6 months back, which was normal, and this time it was 1.48, and it was rising quickly in a matter of a week or so. So on 6th of February it was 1.48, on 7th of December it was 1.5. So story till now, elderly gentleman with multiple comorbidities, diagnosed HIV, doing fairly well on the antiretroviral treatment, currently comes with 2 months of history of fetal edema, hematuria and weight gain. There were so many things which was happening on the urine analysis. If you can notice, there was significant proteinuria. The protein was +3. There was glucoseuria, but he was diabetic, but still we have to consider normoglycemic glucoseuria because he was on TDF. There was a lot of hematuria, microscopic as well as macroscopic. And 10% of those RBCs were dysphonic, which was quite significant. There was some granular cast. All this workup was done by the nephrology unit. His C3 level was low. Chest X-ray was showing bilateral pleural effusion and CRP was borderline raised. He was negative for hepatitis B and hepatitis C. His urine albumin create ratio was elevated, and his 24-hour urinary protein showed a nephrotic range of proteinuria. And I will come back to this, what was anti-phospholipase antibody receptor antibody, which was negative. We'll come back to this. So basically he was diagnosed by a nephro unit as having nephrotic syndrome. His ultrasound showed nothing major but the fatty liver and the mild increased echogenicity bilaterally. And they of course went ahead with the renal biopsy. And the renal biopsy, they confirmed this is a case of membranous nephropathy. Now comes the role of IV. So at this point of time, after diagnosing the membranous nephropathy, they did not know whether it is primary or secondary. They did whatever workup they could do for the secondary nephropathy, like autoimmune workup, connective tissue workup. All those workup was negative. So patient was referred to for the ID consultation, considering this is a idiopathic membranous nephropathy, and they wanted to give him rituximab. So there were 2 reasons for sending this case to ID. One, they wanted to change the ART obviously because the renal functions were deteriorating, and the second thing was they wanted a clearance for rituximab for membranous nephropathy. So at this point of time, this was our thinking process, and I would like to take you through the journey which we had gone during tackling this case. So basically HIV positive on ART, we have to check the current virological status and immunological status, and he was having membranous nephropathy. Probably we were considering switching him to abacavir based regimen or a 2-drug regimen. But definitely we wanted to rule out any OI before we clear him for immunosuppression. So his CD4 count at this point of time was quite good. It was 456 and his CD4 percentage was 28%, and HIV viral load was not detected. So HIV wise he was doing fairly well. So probably we were thinking we will just switch the medication and we'll clear for the rituximab. But this was the glitch. So he was positive for HLA-B 5701. So probably we were not very comfortable for giving abacavir. So we were considering 2-drug regimen, that is 3-TC and DTG for this patient. But before that, we wanted to understand that what is the cause for membranous nephropathy? Is it really idiopathic or it is secondary? There was only one reason, the antibody which I have shown you. If it is idiopathic, it will be positive in most of the cases. But here what we were dealing was with the negative case. So probably it could be a secondary, but secondary to what we do not know. Second and third questions were already going on in the background, that how do we address this case. So whenever we are stuck, we always go for the literature review. So we tried to see what are the causes of renal involvement in HIV, and what we found was generally drugs, infection and HIV associated nephropathies are the common causes of acute kidney injury, which this patient was probably having. But infection we ruled out at this point of time by doing a routine scans and blood workup. Drugs, of course, apart from the tenofovir, he was not on any nephrotoxic drugs. And HIV-associated nephropathy, generally we come across in uncontrolled HIV patient and treatment of which is antiretroviral drugs. Then what are the causes of chronic kidney diseases? There where we found that membranous nephropathy is one of the common cause of renal involvement in HIV, apart from the HIV and hepatitis C virus co-infection. When we were looking for the HIV-associated renal involvement, we wanted to look for what are the causes of membranous nephropathy. So these are all the causes of membranous nephropathy which are secondary. So if it is idiopathic, we are fine, we are comfortable clearing the patient for rituximab. But if it is secondary, we have to rule out each and every cause very carefully before we give clearance for the rituximab. So what we found was there are causes like solid malignant tumors, certain medications, autoimmune diseases like lupus, rheumatoid arthritis or mixed connective tissue diseases. All these things were fairly ruled out already by the nephro side. In infections, hepatitis B, hepatitis C and syphilis were pending. We already got the hepatitis B and hepatitis C which was negative. Of course, we asked for a syphilis at a very first encounter with the patient which was positive. So whether syphilis over here is an innocent bystander and membranous nephropathy is because of something else, or it is the cause for the membranous nephropathy, that was the next question. So what we did, again a literature review, what are the causes, how does the syphilis involves the liver? And as we know about the other, syphilis can involve any body part and he is a great imitator. Similar way, syphilis can involve any structures of the kidneys. It can be glomerular involvement, it can be tubular involvement, it can be vascular involvement, it can cause renal coma. So yes, syphilis can cause membranous nephropathy. So next questions were, is there any causal relationship? Is there only an association or a causal relationship? Even if we say that this renal membranous nephropathy is because of the syphilis, can the treatment of syphilis reverse the nephropathy? That was the second question. Because in that case, we can just elevate the need of the rituximab. So these were the two important questions. We did not have any idea. Even the nephro people did not have any idea. Right? So we went ahead and what we found was the membranous nephropathy was the most common glomerular lesion, and in the biopsy specifically you will notice a full house pattern. While in other forms of membranous nephropathy you will notice one or two antibodies present, while in this cases you will get a full house. So that is what is important, and further literature digging what we found n of cases where they found secondary syphilis causing membranous nephropathy. That was not the only case. Most of the patients responded beautifully and quite quick by giving treatment with the benzathine penicillin. So that was a jackpot for us. So that's why I tell this as a Christmas cake. So another study, 2 cases, both the patients improved wonderfully with the treatment of penicillin. Another study, this was, they did a literature review. What they found was, yes, syphilis is very well known for multiple types of renal involvement in HIV and non-HIV population, and they all respond wonderfully to benzathine penicillin. Another case, very similar to our case, elderly male, multiple comorbidities, virologically, immunologically well controlled, again did very well and complete reversal of renal injury with the penicillin. So this was the jackpot for us. This was a nice study which was done from India. They took all HIV patients and whoever was having a proteinuria of more than 1 gram per 24 hours, that is nephrotic range of proteinuria, they did a biopsy for all these cases. And what they found was HIV was not a very common cause of the nephrotic syndrome in HIV, at least in India. So again, we have to look for the other causes, and HIV can cause all forms of renal involvement. So back to the case, we got few answers. Syphilis can lead to membranous nephropathy, yes. And the treatment of syphilis can reverse the nephropathy. So very confidently we went ahead and we asked nephrologists, wait for the rituximab. Patient was started benzathine and he started showing improvement in a 1 week itself. Later on we had an option of TAF-FTC-BTG. So we started patient on TAF-FTC-BTG. And at 4 weeks of follow-up, there was a significant reduction in proteinuria and creatinine almost normalized. I have already borrowed 4 minutes from Dr. Surbi, my next presenter. Thanks for that. So, on 23rd of December, his creatinine was 1.32 and on 23rd of January, the creatinine was 1. So, nothing, we did not give anything to him. So, this was the take-home message from this case. And luckily, we got the cherry on the cake. How? That was a wonderful story. Whenever we look for any STDs, we never ever leave alone the partners. Right? Yesterday also someone discussed about we should not, forget about the syphilis. So at the very first encounter when we got the report that patient's syphilis is positive, we asked patient's wife's syphilis status to be ordered. Unfortunately, she was not doing well. We did everything telephonically and she was a 60-year-old diabetic female. We never consulted her in person. She was having dyslipidemia. An interesting thing was she had a history of recurrent strokes since 2014. And in 9 years of time period, she had 4 episodes of strokes. She was HIV negative, but TPHS was positive and her VDRL titer was 1:128. We advised them to rule out meningovascular syphilis by doing CSF examination, but they were not willing at this point of time because they were completely taken care by the caretakers and the distant relatives. So, we advised them at least to start the treatment as a latent syphilis with the weekly doses of benzathine penicillin. But when patient came for the next follow-up in the January, we came to know that the patient is admitted again with one more stroke episode and we decided not to leave this opportunity. We called up the neurologist under which the patient was admitted. We asked them to please go ahead, do a CT angiography and do a CSF examination. Although the CSF, VDRL and TPHA were negative, but there was raised protein, total cells of 3. In HIV negative, it is still considerable and her CT angiography showed vasculitis. So again the question is, it is a meningovascular syphilis or it is just an ischemic stroke with latent syphilis? It's a long story but we cannot do it here. So we treated this patient as a neurosyphilis. After that, like in last 2 or 3 years, there were no further episodes of the strokes. So learning point, syphilis is a very important and completely reversible cause for the membranous nephropathy. Partner screening is indispensable. Syphilis can affect any organ system and believe me, the treatment is very, very, very rewarding. So please always look for more. Thank you.
Thank you very much for the very nice presentation. Now we call Dr. Surabhi to present her case.
Well done. Good. Fantastic work. Really very well presented. One of our patients was blind, turned totally blind, recovered. Totally recovered. Back to normal.
A very good afternoon, everyone.
And that's what they need.
Thank the organizers for having me here.
Good work.
So Swati, I owe that you owe me that cake because I have been generous enough to give you my time, and I have to cut a lot of slides. And I also deserve a treat because I am going to give you some break from HIV. So I'm going to discuss a very interesting case which I recently saw. This is a 64-year-old male patient, diabetic hypertensive, known case of severe rheumatic MS with controlled AF on warfarin. So he was referred to us in the OPD by a physician for non-healing painful ulcers, swelling of the tongue and lower lip for a month. And he had already consulted 4 dermatologists and ENT surgeons prior to coming to us. He was treated with acyclovir, augmentin, folic acid, multivitamins without any response. Now we took a detailed history and this man had actually been suffering from significant weight loss, low-grade fever, generalized weakness and dry cough for 6 to 12 months. Also he had suffered from stroke 6 months ago. A diligent search of his files revealed that the histopathology of the clot, which was sent by the interventional neurologist at that point of time, during mechanical thrombectomy was reported as active granulation tissue with clusters of encapsulated yeast suggestive of histoplasmosis. Also, a urinary histoplasma antigen test was reported as weak positive. And when we asked the relatives that why are these reports unaddressed, they could not answer properly But what I could get is that they were confused whether this weak positive has to be considered as significant or not. So probably they were advised to wait. Now these are the oral ulcers and the condition of the oral cavity when he presented to us. And I got the review of the slides which they still were having that was very clearly showing encapsulated fungal yeast suggestive of history. Now when he came to us, his CBC was pretty much normal. We did a transthoracic echo at that point of time because he had already suffered from a stroke which looks like an embolic stroke. Blood cultures were sent which were negative, and we immediately started this patient on liposomal amphotericin B. Now we repeatedly and very strongly advised him to undergo for a transesophageal echo, but the patient refused. Also at that point of time he was having those ulcers, so he said, I'll come later on, but he never turned up for TEE. There was significant improvement in cough and oral ulcers in a week. He started taking orally and he was discharged on liposomal amphotericin B with the promise that he would come to the OPD for TEE. However, he didn't come, and after a week he was admitted in UL Mehta Cardiac Institute with acute onset dyspnea and chest pain. He was in cardiac failure with a very fast ventricular rate. And there they diagnosed that he had a vegetation on the mitral valve at that point of time, which was not present on the transthoracic echo when we checked it. So he was stabilized there and he was shifted back to our hospital, planning for mitral valve replacement. Also, we had done a CT chest at that point of time, which showed bilateral multiple nodules with non-necrotic mediastinal lymph nodes, which also looked like histoplasma. His urinary histoplasma antigen, which was repeated, that also was positive. And this is the echo which is showing around 14 by 7 millimeters vegetation on the mitral valve. And he was taken for early surgery after he was stabilized. And the histopath of vegetation also was suggestive of histoplasmosis. On liposomal amphotericin B, he became afebrile, the cough resolved completely, oral ulcers healed, and he gained very good weight. He received about 8 weeks of amphotericin B, followed by oral hexabiconazole, and the patient did very well. Now when we went back to the risk factors, if we find them, there was a strong risk factor that he was daily in the morning doing yoga on his terrace, and his mat used to be surrounded by bird droppings. So he used to practice deep breathing exercise there for a very long tenure. So histoplasmosis is caused by Histoplasma capsulatum, which is a dimorphic fungus. Soil contaminated with bird or bat droppings acts as the main reservoir. While acute form of infection is most commonly seen in immunocompromised hosts, chronic histoplasmosis primarily affects immunocompetent adults. The clinical manifestations can be varied. For the saving the time, I have not gone into the details of the clinical manifestations, but it could be asymptomatic to symptomatic pulmonary to disseminated histoplasmosis, and again acute versus chronic. The diagnosis, we usually use urinary histoplasma antigen, which is a very easily available test these days, and fungal cultures will remain the gold standard, of course, and histopathology. Antifungals of choice for mild cases, mild to moderate, especially those which are limited to pulmonary, there an oral azole is good. However, in cases like this, we usually start with liposomal amphotericin B followed by an azole. And itraconazole, posaconazole, voriconazole, they all have been used. There is data. We used isabiconazole in this patient because he was on warfarin, and that is the only oral azole where we are not worried about the drug-drug interactions. Thank you.
Congratulations, Dr. Trupti, for excellent case presentation. Due to time constraint, we may allow only one question from audience.
This is regarding Swati Goel's presentation. Very nice presentation on syphilitic cake and syphilitic cherry on that. The problem with syphilis everywhere that most of the labs are not doing TPHA titer. They just do TPHA positive or negative. That doesn't signify anything because TPHA takes long time, maybe years and years to become negative. And in Vidaran titer, Sometimes they do up to 8 or 12, 16, they don't do beyond that because it's a tedious procedure. And therefore, clinicians get misguided. They don't treat syphilis. And in many labs, 1 in 4 or 1 in 8 is a standard titer. So it is not considered a significant titer. So therefore, you miss syphilis cases. Secondly, when we take a history of patient, we talk only about patient or bi. Many of such cases are bisexual, and we never take that history. So I think history taking is very important. Ping pong infection, maybe there are a couple of forms, they need to be caught and treated, and then only you come to know. Now coming to neurosyphilis, it is the generalized paralysis of insect or temis dorsalis. And again very difficult to catch because of aging, because of other issues, but their titers are very high. And their titers do not come down even after treatment very quickly. So syphilitic titers come down very quickly if it is a recent infection, and maybe secondary syphilis, but tertiary syphilis, quaternary syphilis, they don't come down quickly.
Thank you, sir. Thank you. I think now we close the session.
Thank you. I request our chairs to kindly hand over a token of appreciation to the speakers of this session.
Can I have a small question? So before starting with hepatitis B, how do we define hepatitis B? Means only on HbA or anybody can answer what the expert were went on. If I want to start tenofovir based regimen, only I should believe HbA positive status, or we should go for any other antibodies, because sometimes the patient may not respond and later on will come to know the something is going bad in the liver.
So, no, if I can give a short attempt to answer the question. So I think what we do is we check for HBs antigen because that is the sign for chronic infection if it's there for 6 months. But we also, in case that's negative, do anti-HBC and anti-HBs because you want to know whether you want to vaccinate or whether there was a past infection, because you had past infection that is important in the future in case of immunosuppression for chemotherapy, because then you need to intervene. So if you would have someone who has anti-HBC and has past infection, you would be free to use a different antiviral regimen without tenofovir. But if the patient ever gets immunosuppressed, then you would have to add tenofovir to the mix.
Thank you.
I request the chairs to hand over a token of appreciation to Dr. Trupti and Dr. Crystal.
Answers my question. Yeah, I was just checking the panel which we have. Unfortunately, does not have this is a commercial panel. So we can actually develop in case it wants to take think about it later. Okay, thanks.
Dr. Surbi Madan. And I request Dr. Dilip Mathai to kindly hand over a token of appreciation to the chairs for this session. Dr. Diwakar, Tejaswi, and Dr. Jayendra Kosambiya.